Foremost, the main reason for a vaccine mandate is to ensure that we don't exercise undue burden on our healthcare facilities. And we need to be clear about this, that unvaccinated people are more likely to end up in hospital than vaccinated people. And yes, they might want to make a choice of remaining unvaccinated and take that risk of ending up in hospital. That is their right. But at the same time, unfortunately, there's someone else that actually pays for that ill-informed choice, and that is a taxpayer. So then we have a situation that when you get 95% of the population vaccinated, you get significant disruption in terms of the ability of the virus to transmit in a community.
Hello, my name is Donald, and welcome to the #1 media company, WorldView. At WorldView, we explore everyone's perspectives on all things that can broaden our worldview. Today, we're going to talk with Professor Shabir Madhi. The professor is the Dean of the Faculty of Health Sciences, Professor of Vaccinology at Wits, and the co-founder and co-director of the African Leadership Initiative for Vaccinology Expertise. He is leading the first two COVID-19 vaccine studies being undertaken in Africa. Professor, good afternoon. Welcome to the show. It's great to have you on. First question, a lot of South Africans feel that the lockdowns were a bit too stringent. Do you think in hindsight that these lockdowns were necessary to reduce the spread of COVID-19 and opening up much needed hospital space?
Good afternoon. Thank you for having me. So obviously, it's always quite easy to look in hindsight as to whether the decision was correct or not. But at the same time, it's not only about looking in hindsight, but also reflecting on what was said at a time when South Africa initially went to high levels of restriction. So unlike many other countries, and especially European countries, which really started to go into high level of restriction at a time when they were experiencing a surge during the course of the first wave, in South Africa, the government decided to go to a high level of restriction prior to the surge of the first wave, when just the initial few cases were being identified. And the reason why they embarked on that particular course of action was they were trying to replicate, in a sense, what was shown in China as well as South Korea, where those countries were effectively able to contain the spread of the virus by going into this high level of restriction when there were a limited number of cases that were that were being identified. Unfortunately, in the South African context, it was always doomed to fail, in that it was given our complex society and the socioeconomic conditions on the ground, the chances of South Africa being able to replicate what was done in China was extremely remote to start off with. So although the high level of restrictions during the course of the first wave and initial phase of the first wave spread out the period of time over which infections occurred, it didn't prevent infections from taking place, and that is very important. So the restrictions in South Africa, in fact, has probably had a very nominal effect in terms of the number of people that were infected. But during the course of each of the waves, when we went to a higher level of restrictions, it probably spread out the infections that took place over a longer period of time, probably extending it by about 1 to 2 weeks. Now, that does become important when it comes to healthcare facility utilization, because even spreading out these infections over a 1 to 2 week period means that a number of hospitalizations that are occurring will be spread out over the same period of time, and consequently, the healthcare facilities will be slightly better equipped to be able to deal with a number of cases that are presenting. So it didn't prevent infections from taking place, but certainly during the course of the first wave and possibly during the course of the second wave, it did assist in terms of healthcare facility, the pressure that was on healthcare facilities.
And the ban on cigarettes and alcohol?
Yeah, so the ban of cigarettes, unfortunately, that really didn't have much value at all. And in fact, recently there's a fair amount of data, including from South Africa, which surprisingly shows that people that do smoke actually were less likely to be infected with the virus than non-smokers, which just come as a bit of a surprise, and not just in South Africa. In fact, even in a study in Austria, they had a very similar sort of finding. But at the same time, it doesn't mean that smoking is healthy for you. because those individuals that do become infected with the virus, if they are smokers, they're more likely to end up then developing severe disease. And in fact, the immune response to the infection is very different compared to people that are not smokers. But smoking itself certainly didn't, or the ban on smoking didn't have any contribution when it came to preventing infections from taking place. On the other hand, the alcohol ban, there was a different dimension to it. So it wasn't that alcohol was going to, or the use of alcohol was going to increase your risk of developing COVID. Certainly, the use of alcohol in places such as what we refer to as shebeens or informal places where people gather to drink in large numbers, that would be reckless because it would end up with people mingling without taking necessary precautions. And consequently, the chances of spread of the virus being much more rapid does exist. But the main reason why the alcohol ban was imposed in South Africa was more to do with the reality in South Africa that alcohol is responsible for a fair amount of trauma that is experienced, be it motor vehicle accidents or be it other sorts of violence that occurs in society when people are not responsible with the use of alcohol. And those sort of trauma and violence associated outcomes related to alcohol abuse, unfortunately, it does put a pressure on the healthcare facilities. So what we couldn't afford for to happen is that whilst healthcare facilities were under pressure on the one hand because of COVID-19 and the surge of cases, at the same time needing to deal with ongoing pressure on healthcare facilities for admission of trauma cases, which could be avoided by the use by not permitting alcohol sales. And that probably was somewhat successful in that during the course of the COVID waves, and in fact, for the past year, the amount of trauma-related hospitalizations in South Africa has been significantly lower than what was experienced before COVID-19. And I think much of that is related to having decreased the abuse of alcohol.
That's interesting. Professor, what is the argument in favor of wearing masks to reduce the spread of COVID? Because even if it made sense, even if it were effective, it seems like most individuals do not take the necessary precautions in sanitizing their masks and not borrowing each other's masks. So most individuals don't take it very seriously. So isn't it a bit frivolous to wear masks?
Certainly, and it depends what type of mask you're wearing and for what purpose. So when we started to advocate for the use of masks, it wasn't really to protect the individual from becoming infected, but rather to decrease the likelihood of the person that is infected from transmitting the virus into the surrounding space. But for that even to be successful, you need to be wearing the right type of mask and it needs to be worn correctly. So the type of mask that most people use, a material mask as an example in South Africa, which is just a single layer of cloth, doesn't actually, and it doesn't have a very tight seal around the nose, the eye, the mouth, etc. Doesn't do much in terms of preventing transmission of the virus or even protecting an individual from becoming infected. So to some extent, unfortunately, it's very much what I would term as COVID theater, that we're going through the motions without really gaining much from those sort of activities. And in fact, to a large extent, probably detracting from what is most important, especially during this phase of the pandemic, which still remains vaccines, rather than believing that the use of this cloth mask is having any substantial impact when it comes to reducing the amount of virus that is being transmitted by infected individuals. Obviously, in a hospital healthcare facility environment, it's a very different story, especially when you're using the equivalent of the N95 mask, which are able to sort of filter out the type of microscopic particles in which the virus can be found and end up infecting people. So the use of the N95 mask, especially when used correctly in a healthcare facility, makes perfect sense. There might be individuals in a community that are at high risk, even if they are vaccinated, that might still want to protect themselves from being infected. And those individuals should, again, be using the right type of mask and wearing it correctly. But at this phase of the pandemic, very little role for the use of face masks, and certainly not the type of masks that have been used in South Africa. 95% of people that use any sort of mask in South Africa are using the incorrect type of actually wearing it correctly. So it means it's actually providing very little either direct or indirect benefit.
That's fascinating. So would you argue that we should end the mask mandate?
Certainly. I don't think, especially wearing a mask outdoors, even makes less sense than anything else. But even indoors, if we are wanting to continue with a mask mandate, then we need to be wearing the right type of mask, and we need to be wearing it correctly. And that does not equate the type of mask, which, as I mentioned, the majority of South Africans are wearing. So very little use for masks. And again, it's nothing but the pretense of doing something, but achieving very little with doing it.
So, Professor, the next question might be a bit controversial, but can the vaccine technically be described as a vaccine? Because as far as I know, and you can correct me if I'm wrong, the vaccine does not prevent the spread of COVID, nor does it make you immune to the disease. So can one technically describe it as a vaccine?
Well, a vaccine is defined by what it does. And what vaccines does is that it stimulates the immune system and produces a type of immune response which has a range of different sort of activity when someone is exposed to a germ. So the fact that a vaccine doesn't protect against infection doesn't mean it's not a vaccine. It means that it is not inducing the type of immune response that is required to protect against infection. Never in the history of mankind have we ever produced a vaccine to prevent infections. Vaccines have always been, and even to this day, have always been developed primarily to protect against severe disease and death. That's the main role of vaccines. We don't have vaccines against a common cold because it's not something that is clinically significant. It causes someone to be miserable for a few hours or maybe 1 or 2 days. But beyond that, we're not interested in it because it doesn't cause large number of people to die. So it's not that we don't have the technology to be able to develop vaccines against a common cold, but we simply don't bother doing it because we know that not even a handful of people who die of the common cold. But with COVID-19, we know that thousands, hundreds of thousands. In South Africa, close to 300,000 people that have died of COVID-19. Now, when we develop vaccines, like I said, it's not about what it's about what a vaccine is. A vaccine induces an immune response in an artificial manner to equip the body to be able to combat the effects of an infection when that infection does materialize. Now, what we see with COVID-19 vaccines is that these vaccines work differently when it comes to how well it protects against infection. As an example, against the ancestry virus, the vaccines worked extremely well, 90% protection against infection due to the ancestry virus. But then the virus started to mutate and became relatively antibody evasive. So we had a beta variant, as an example, in South Africa, where AstraZeneca vaccine didn't protect against infection due to the beta variant, but yet the AstraZeneca vaccine protected against hospitalization due to the beta variant, reducing the risk by up to 80%. Omicron has been no different. When it comes to vaccines, the vaccines 1 or 2 doses haven't protected too well, if anything, against infection due to the virus. But what they've done is they've reduced the risk of being hospitalized and dying from COVID-19 by 70 to 90%. So we need to be clear that when we talk of vaccines, it's not about the outcome. Vaccines per se is a technology that's used to basically induce a certain type of response in the body. And that response in the body then determines what the vaccine would be able to achieve. And the main goal of vaccine, again, to emphasize, is protection of severe disease and death. When vaccines do protect against infection, and some vaccines work very well in protecting against infection, in those instances, that's a super bonus. It's something that we most welcome because when vaccines start protecting against infection, it allows us to then start talking the language of being able to get to herd immunity, which, as an example, is the case for measles.
But comparatively speaking, doesn't, for example, the polio vaccine make you completely immune to that disease?
No, absolutely not. People still get infected with polio, but they don't develop paralysis from polio. That's the difference. And the reason they don't develop paralysis from polio is because the vaccine protects them against severe disease and also attenuates the clinical cause of the infection that occurs from the virus. And obviously, polio is largely eradicated. So probably not too good an example. Let's take measles rather, and polio is a different type of, is a virus that spreads in a very different manner compared with COVID. That is more in what we call an enteric pathogen, mainly spread through the fecal oral route, whereas COVID mainly spreads through the airborne transmission, similar to measles. So when you look at measles, when people are vaccinated against measles, they can still get infected with the virus, but they have a very mild infection which largely goes by unnoticed. Because the measles virus is unable to have the same type of mutations that makes it relatively resistant to the immunity that is conferred by vaccines. So then we have a situation that when you get 95% of the population vaccinated, you get significant disruption in terms of the ability of the virus to transmit in a community. So it's impossible to make head-to-head comparisons of one vaccine against another because the immune responses they're eliciting are different, and the pathogen against which they're targeting an immune response is different. The pathogen might be unstable, such as SARS-CoV-2 with regard to frequent mutations, or the mutations might not be clinically relevant with regard to the type of immune response that is induced by vaccines. So I would guard against making any head-to-head comparison between any two vaccines. There's no two vaccines that work in the same way and that have the same sort of an outcome.
Yeah, that's very interesting. I didn't know that. Professor, so the main rationale for the vaccine mandate would be then to prevent the spread of mutants, variants.
Well, when we talk of vaccine mandate, foremost, the main reason for a vaccine mandate is to ensure that we don't exercise undue burden on our healthcare facilities. And we need to be clear about this, that unvaccinated people are more likely to end up in hospital than vaccinated people. And yes, they might want to make a choice of remaining unvaccinated and take that risk of ending up in hospital. That is their right. But at the same time, unfortunately, there's someone else that actually pays for that ill-informed choice, and that is the taxpayer. Because when those people end up in hospital in the public sector, it is the taxpayer that is needing to then bankroll their management in the public sector because of their poor choice of not wanting to be vaccinated. So from a societal perspective, I'm not even going to we'll talk about the transmission part of it, but from a societal perspective, when people choose to be unvaccinated, it's not just about an individual choice, because it is a choice which comes with a consequence, and especially if people are at high risk of developing severe disease, that consequence is ending up in hospital, and when they end up in hospital, they can't be deprived of care, and the people that are responsible then for bankrolling their stay in a hospital in the public sector are the taxpayers. In the private sector, the people that are responsible for bankrolling the stay of an individual that was unvaccinated that ends up in hospital are other members of that particular medical aid scheme. So it comes with consequences, and it goes beyond the individual in terms of the consequences that materialize. Now, that is from a societal perspective where we're wanting to ensure that we can maximize our ability to prevent hospitalization and death. When it comes to transmission of the virus, so what we've now come to see with the Omicron variant is that these vaccines on their own don't protect too well against preventing infection from taking place. And people that are infected, what ends up happening is that although they start off with what we refer to as a very high viral load, the duration of time that they actually shed the virus is actually less than an unvaccinated individual that has become infected. So it means that although they end up being infected with the virus. Once they're infected with the virus, once they've got these breakthrough infections, they're less likely to transmit the virus if they've been vaccinated. And they're even less likely to transmit the virus if they've got immunity, which has resulted both as a result of infection as well as vaccination. So people that have what we refer to as hybrid immunity, vaccine plus infection-induced immunity, actually have a more robust immune response than people that have only got infection-induced immunity or only vaccine-induced immunity. Now, that doesn't mean we want people to get infected, but unfortunately, the reality in South Africa is that even before the Omicron wave, inadvertently, 70% of the population ended up getting infected. Now, when 70% of the population have ended up getting infection, you've got extensive amount of protection against severe disease and death. And that's the reason why the Omicron wave was less severe than what we experienced in the past. But we can do better in that if those people that were infected as well as uninfected people do get vaccinated, when there is another resurgence, it's very likely that that next resurgence will be of a lower magnitude than what Omicron was, even in South Africa.
Professor, isn't the first leg of your argument, the argument in favor of society, a bit of a slippery slope? Because one can argue that we should ban the use of sugar because that increases your chance of ending up in a hospital. which a taxpayer would have to pay for.
Well, but that's what we already do. We already impose taxes on sugar. We already impose restrictions on people driving under the influence of liquor. We already impose restrictions on people having guns in the public domain. We've got a number of restrictions, all that are geared to the betterment of society and to the protection of society at large, rather than an individual self-centered interest of an individual. So we've got those regulations. We've lived with those regulations all our lives. So I find it surprising that all of a sudden people are claiming individual rights when in the past they haven't made a case and they haven't fought why they shouldn't be allowed to drink liquor in public, or why they shouldn't be allowed to operate a motor vehicle whilst under the influence of liquor.
Yeah, okay, fair enough. Professor, what's the difference between a booster shot and a vaccine?
Yeah, so all a booster shot really refers to is, well, a booster, when we boost, we're still using a vaccine. So we use vaccines for some diseases, and for some vaccines you might need one dose. For some diseases and vaccines you might require 2 doses. For other vaccines you might require 3 doses. So let's take measles, let's take the childhood vaccines. There's a vaccine known as the pneumococcal conjugate vaccine that protects children from developing pneumonia, infection of the lung. Children require 3 of those doses during their first 2 years of life to get good protection against pneumonia. When you look at measles, children only require 2 doses of the measles vaccine, and at a later stage in life to be protected against measles. So there isn't any magic number that applies to all vaccines as to the number of doses that are required. It needs to be tailored for a particular vaccine and what the vaccine is able to accomplish, given whether you're giving 1, 2, or 3 doses, and sometimes even 4 doses. So in children, we do have vaccines where children receive 4 doses of vaccine. As an example, whooping cough is an example where children get 3 doses in the first year of life, another dose in the second year of life, and then another dose when they enter into school. And every 10 years later, they're supposed to get another dose. So it's not exceptional for COVID-19 for us to go beyond a single dose of vaccine and to require these booster doses. What the booster doses of vaccines are doing, that is additional doses of vaccines, is that it's trying to enhance the immune response, which has been elicited following the initial 1 or 2 doses of vaccine. So you're basically trying to enhance the immune response. Now, we also need to be careful about why we're boosting. So a country such as Israel, when they're trying to boost for a 4th dose of vaccine, they're not trying to protect against severe disease and death, because they can accomplish that just with 2 doses of vaccine for the majority of the population and 3 doses in individuals that are at high risk of developing severe disease. Why they're providing a 4th dose of vaccine is to try to prevent infections. And for me, that is a game that you're bound to lose. We don't have the type of vaccines that would be able to persistently protect against infection due to the virus. We do have vaccines that work very well in protecting against severe disease and death. So booster doses of vaccine, all that it means is that it's still a vaccine, but it's just an additional dose of the same vaccine that's being given. Sometimes you might want to use different sort of combinations of vaccines. As an example, a messenger RNA vaccine followed by the non-replicating vector-based vaccine. And that combination, in fact, ends up being superior. It ends up inducing a very different sort of immune response compared to 2 doses of the messenger RNA vaccines or 2 doses of the non-replicating vector-based vaccines.
Why do some individuals get ill when they take the vaccine or the booster shot for a short duration?
Sure. So when you get vaccinated, what you're trying to do is you're trying to induce an immune response. And the magnitude of the immune response does differ between individuals. And depending on the magnitude of the immune response, it releases what we call pro-inflammatory cytokines, these chemicals. And these chemicals are also chemicals that are induced in a much more uncontrolled manner when someone is actually infected with an organism. And it ends up with much more severe sequelae. So it's this stimulation of the immune response that releases this sort of chemicals, which results in a type of side effects that people often would encounter, which is transient. As an example of fever or even headache, lethargy, sometimes muscle ache, and that usually lasts perhaps maybe 1 to 3 days. Usually self-limiting, but it's really an indication that the vaccine is stimulating an immune response. And those sort of side effects are not, again, unique to COVID-19. These side effects are very common with even seasonal influenza vaccine as an example. Between 30 to 40% of people that received a flu vaccine would have a similar spectrum of side effects.
Can the side effects be fatal?
Unfortunately, all vaccines do come with some risks, but the risk-benefit ratio is far in favor of the benefit. So what is the chances of a fatal side effect from COVID-19 vaccines? Currently, the best estimate is around about 1 to 2 in a million, ending up with a fatal side effect, 1 to 2 per million. To put that into context, the chances of dying of a lightning strike in South Africa is probably in a region of about 4 in a million. So you're more likely to die of a lightning strike in South Africa than to die because of a fatal side effect of a vaccine.
Yeah, interesting. Professor, a lot of people criticize the World Health Organization and the CDC in America for being slightly inconsistent. I know, for example, there's some criticism for the World Health Organization that it's too much influenced by China. Do you think these two organizations are trustworthy?
Well, I think they're trustworthy. They might not always have got their messaging correct. And in fact, I've been at odds with the WHO on a number of occasions when they were advocating one course of action, which I and others in South Africa believed there wasn't actually appropriate for South Africa. So right during the course of the first wave, as an example, when WHO kept on harping that countries should keep their restrictions at high levels to prevent the spread of the virus, it was clearly evident in South Africa that that sort of approach was not actually working and in fact was causing more harm than good from a societal perspective. Another example is WHO were very late to actually endorse the use of face masks and were actually very late even to recognize the main mode of spread of the virus was through the airborne transmission rather than through direct contact, which is when the physical distancing between people really works. So yes, they've got it wrong on a number of occasions, but I don't think they got it wrong for ulterior motives. Unfortunately, at times they were just misguided in terms of their recommendations and weren't necessarily able to make recommendations that should have been customized for different localities given the reality on the ground. When WHO starts making recommendations and asks all countries to actually sort of consider adopting those recommendations without understanding what the material conditions are, that becomes problematic. And then that creates uncertainty about the type of advice that comes out from those sort of institutions.
Professor, a lot of people in so-called right-wing circles say that natural immunity is much better method of fighting COVID than the vaccine and the booster shot. What is the argument against natural immunity?
Well, a simple argument against natural infection immunity is that it comes at massive cost of life. As I mentioned, in South Africa, there's close to 300,000 people that have died of COVID-19. Globally, the figure is probably 3 to 5 times more than the number of cases that have actually been recorded today. A country such as India, as an example, where they've recorded 450,000 people having died of COVID-19, the modeling indicates that that figure is probably in the region of 3 to 4 million for India alone. So natural infection does induce immunity without any question, and it probably protects you against severe disease. It probably protects less well against infection compared with vaccines, and is less predictable in terms of how well it protects against infection. But when it comes to protecting against severe disease, natural infection probably works as well as vaccines in protecting against severe disease. But like I said, it comes at a cost, and the cost is that you lose lives. People die, and those people that have died would argue against trying to adopt natural infection as a modality to develop immunity against COVID because they don't have the choice any longer. But there is another element to this. Inadvertently, we've ended up in a situation in South Africa, as an example, where even due to even before the Omicron wave, 70% of people had become infected with the virus inadvertently. It wasn't by design, but it's just a reality that we weren't able to prevent spread of infections taking place. After Omicron wave, that figure probably says that 80% of people have been infected with the virus at least once since the start of the pandemic. Now, that natural infection-induced immunity, together with vaccination, that hybrid, what we refer to as hybrid immunity, that is the most potent type of immunity that you can get in protecting not against severe disease and death only, but also in terms of enhancing protection against infection and reducing the ability to transmit the virus. So people that have been infected with the virus, yes, they are protected against severe disease, but they can be even more protected now against infection, and they can actually reduce their chances of transmitting the virus if they do have a breakthrough infection compared to someone that has only developed immunity either just from vaccines or only because of infection.
Do you think we will ever see an end to the different COVID variants?
No, I think we need to become comfortable with the reality that the virus is going to continue mutating. There will be new variants that will arise in the future. But it's very unlikely that further variants will be too different from Omicron, at least when it comes to how well either natural infection or vaccine-induced immunity, or the combination of the two, protect against severe disease. So the type of mutations that we've seen up until now with COVID-19 are mainly mutations that are able to evade what we refer to as antibody response, antibody activity of that's induced by infection and vaccines. But there's another arm of the immune system which is a bit more resilient and which these variants haven't been able to affect too much. That is known as the T-cell immunity. And the T-cell immunity seems to be especially important when it comes to protecting against severe disease and death. So yes, we will have another resurgence in a country such as South Africa and elsewhere. There very likely will be new variants that will arise over time. But we've got the tools in place now that these tools will assist us in terms of mitigating the consequences of severe disease and death after infections have transpired.
Now, with the tools available to us, do you see light at the end of the tunnel? Do you think this will end eventually and we can get back to normal?
Absolutely, and I think countries such as Belgium, countries such as Denmark, such as United Kingdom, and many other countries are likely to follow very soon. They have pretty much listed all sorts of restrictions around COVID-19, and that is where South Africa certainly should be at this point in time. There's very little reason for us to be keeping any of the type of restrictions that currently are in place. To keep any of those restrictions in place. It includes things such as outdoor gatherings. There's absolutely zero reason for people to wear face masks when outdoors, and no reason not to open up sports facilities to spectators. Indoors, similarly, we need to have a much more nuanced approach. People need to be vaccinated, especially when they're in regular indoor gatherings. And again, people might not like to hear the word mandatory vaccination, but I still believe that when people are going to gather on a regular basis in indoor spaces, there still should be a requirement for vaccination. And like I said, even if they've been infected, that vaccination basically gives them super immunity, which protects them against infection as well as reduce the chances of them transmitting the virus. But we shouldn't require people to wear face masks indoors. Yes, at an individual level, people that are at high risk of developing severe disease, when there is an increase in number of cases, they might want to take that added precaution of still wearing a face mask, but then they need to wear the correct face mask to be protected against infection. But at the mass level, very little reason to be wearing face masks, to be restricting outdoor gatherings to any number for that matter.
Well, thank you, Professor. This has been such an informative and interesting discussion. I want to give you one last opportunity if you want to add, plug, or say anything that you want to.
Yeah, it's been a difficult 2 years, and I think we need to draw comfort from the reality that we are in a very different phase of this pandemic. Like I mentioned, it has come at a massive cost of life, something that is unparalleled over such a short duration of time, over the past century probably. So it's come at a huge cost of life. But at the same time, we need to now get back to a relatively normal lifestyle. We need to stop restrictions which are causing more harm than good. And the type of restrictions that are still in place, including limitations on outdoor gatherings, wearing face masks when those face masks are not achieving much. Those are type of restrictions which are actually burdensome and not returning any value for money. So we need to get back to a relatively normal lifestyle. This is not the end of COVID. Unfortunately, people are still likely to die of COVID in the next year and into the future. But it's extremely unlikely that in South Africa, as an example, COVID is going to cause even half the number of deaths compared with what the number of deaths is going to be experienced from TB. So this year in 2022 in South Africa, we estimate there will probably be about 58,000 people that will die of tuberculosis. Even if we stop all restrictions against related to COVID, we probably won't even reach 20 to 25,000 people, which is still a large number that will die of COVID-19. And that figure of 20 to 25,000 is about the same number of people that end up dying in South Africa because of motor vehicle accidents.
Well, thank you, Professor. Thank you for your time. To our viewers, if you've made it this far, please consider liking this video, sharing it as widely as possible, and subscribing to our channel. My name is Donald, and you've been watching WorldView.